Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
This is Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. Thank you for joining us for this series on ethical considerations and medical error communication. Joining me for this discussion is an expert in law and healthcare, being a nurse and lawyer, Dr. James Stowe. Thank you for joining us, Jay.
Hey, it's great to be here. Thank you.
Yes, we know that medical errors are an unfortunate reality in healthcare, and they come with some potentially devastating consequences for patients, for families, and for healthcare workers. So before we really kick off this conversation, I do want to highlight that the ethical considerations surrounding medical error communication are multifaceted, and they demand careful navigation. While transparency and accountability are crucial, we also have to prioritize the well-being and the trust of patients and families. So now, Jay, this seems like a really easy question, okay? But when you break down medical errors, there's really more to it than the surface definition. So my question, what is considered a medical error?
You know, it all depends on who you ask. Unfortunately, that's not a very easy answer because there's, as you mentioned, there's so much built behind that word, so much fear when you say medical error and so much concern. But many institutions, and I think the National Institute of Health has kind of summed it up a little bit better and gave the definition. A medical error is a failure of a planned action to be completed as intended or the use of a wrong plan to achieve an aim. So it's pretty broad in its scope, and really, does that give you any additional clarity when you do that? I don't know. It's kind of broad there.
It is, for sure. All right, so what causes medical errors? What is that factor behind a medical error?
When first thinking about this topic of medical errors, it's really something that is interesting to me as both a nurse and an attorney. I have practiced with some medical lawsuits, a number of them in my career. And you look at it, and looking back, there's roughly, depending on what research you look at, 200 to 400,000 plus deaths a year attributed to medical errors.
Oh my gosh.
It really ranks roughly, when you take COVID out of the picture in any given kind of normal, quote unquote, normal year, about the third leading cause of death. Well, that's death.
Yeah.
Right. So how many actual errors, how many missed dose or wrong dose of medication is given that cause no harm, but that's an error. How many actual errors really did occur? So it's many, many times more than that 200 to 400,000. So what causes it? I think it's multifactorial. There's, did you get enough sleep the night before?
No, probably not.
Are you overworked? Are you stressed out? Are you worried about a loved one? Child's soccer game was this afternoon. You're just worried whether or not they'll do well, and you take your mind off of what you're doing for just a second.
Yeah.
So there's so many things that can interfere with your focus when you're working that what it does is it shows us by the number that it's pretty darn easy to make a medical error.
Absolutely. And then it's not even just human factors. What about miscommunication between provider and staff, and system and process deficiencies? I mean, those seem to...
It's amazing. Recently there was a lawsuit out of Tennessee, Nashville, a criminal trial from a nurse that admitted mistake. It got national attention, the Redonda Vault case. But there were errors in the processes. right? And for example, when searching for a medication in the Pyxis machine, the medication dispensing machine, it only put in the first two letters versus the first three that would have narrowed down the medication options to choose from. Well, that's simply a programming error. So how does someone in an IT department programming a computer understand the frontline necessity of a third letter versus a second one? It can get really granular, and it's difficult. There's no easy answer when trying to define everything, because if you could define it all, you could fix it, right?
Right.
But you just can't define it all because you have these really interesting one-offs that just keep popping up.
It seems like with medical errors, there's quite a few different types. So we've talked about system and process errors, communication errors, treatment errors, mistakes in medications and procedures and surgical, diagnostic errors.
Absolutely. If you can think of healthcare, there's an error associated with it. Now, when we think of medical errors, of course, my thought process with my history and being an attorney, I kind of jump to the most egregious examples, right?
Right.
Severe bodily injury, harm, or death.
Yes.
But most errors are unintentional. They're not intentional. They're not I'm going to do this because I intend to harm a patient. That's really not the case. The result may be harm, but the actual practice, whether you're in a urgent care, whether you're in a dentist office, are you in a pharmacy and you've got 19 people waiting in line in a pharmacy, are you really double checking the medications that you're dispensing as close as you need to? So medical
I
errors
don't think
can
so.
happen anywhere. I mean, it really can happen in anywhere, in any setting.
Yeah.
So errors happen every day.
Well, we're human, and they're going to happen. So what are the key ethical principles that should guide the communication of medical errors to patients and families?
This is really interesting because you get a lot of suggestions of what you should do, but no one has gone out and defined it and said, this is what you have to do. I can tell you from my experience and having sat at the boardroom table more times than I care to admit when talking with patients and patients' families about medical errors, that if you're sitting at the boardroom table talking to a patient or their family about a medical error, there was a bad outcome, right? The key tenets are you're going to have to be honest. If you've made the decision to go to the table, to sit at the table, you're going to have to be honest, and you're going to have to talk to them and tell them exactly what happened. So honesty on the forefront. Disclose the error. Disclose exactly what happened and exactly what you're doing. This is what happened. We're doing this. Our focus is on the care and well-being going forward. How do we optimize health? How do we get, mom, dad, brother, sister out of the hospital, even though there was some harm done? What do we have to do moving forward? And I will say this. If you don't come across as sympathetic and caring, it's all for naught, right? Don't treat it as an exercise of, well, this is just something I have to do. You got to be sincere. If you're going to reveal that, you got to be sincere. There's some very important and strong legal implications by sitting at the table and disclosing these errors. So sympathetic approach really is important.
Yeah. And then do you also bring into that discussion how to prevent or how we're looking at preventing? So if you're being transparent and honest about what happened, is it helpful to bring in, well, this is what we're doing to try to prevent it in the future?
It's really interesting, that question. That can go two ways. It always depends on the receiving individuals, right? If the receiving individuals are taking in your message and you see head nods and they're following along and they truly appreciate what you're doing, and you don't want this error to your loved one to happen again, that can be a very impactful thing. And it can make a strong statement, and the patient or the family can truly enjoy that.
Mm-hmm.
If you're not getting a lot of warm and fuzzy from the other side of the table, what can be taken out of that is replaying those statements. If they do decide to sue, replaying those statements in court of this, and imagine how this goes over. Yes, the hospital told me that this has happened repeatedly, and they are created a task force to change that going forward. Well, I would have a field day as an attorney. So it's repeatedly happened and you haven't fixed it by now. So it's really. So when we talk about standards and talk about hard defined rules on what you can and can't say, there aren't any, because it's really up to how your conversation and how the receiving party is going to take your comments and your sincerity.
Right. Okay. So morally, ethically, legally, am I obligated as a healthcare provider to disclose medical errors, even if the error does not result in, say, harm to the patient?
Morally, ethically, I believe that you are. Now, again, that's coming from my morals and my moral compass, right? So one of the issues that we have today is everybody's an individual, and everybody theoretically has their own moral compass. So what do they feel like they need to do? Well, how do you correlate that into expectations or a standard or a rule that you must follow? When you look at a hospital, and I'll pick on hospitals, I should say healthcare institutions, whether it's a dental practice, a pharmacy, urgent care. Do you want a written policy that says, hey, this is how we're going to handle medical errors? Again, as an attorney, I can get a copy of your policy and hold it up in court and say, hey, look, they have
a guideline.
They have so many messed up processes. They had to write a procedure about it. The optics just aren't good, right? So what you end up finding and seeing is that the few places that there are actual written expectations are in your licensing agencies. So your boards of nursing, your medical boards will tell you you have an ethical obligation to admit errors, tell it to the patient, family, whomever, to receive that information and provide care. The other way to look at that is, if you've assumed care over an individual, you kind of created a fiduciary partnership, right? You've created a fiduciary duty, and part of that duty is doing no harm, no malfeasance. So if you don't do any malfeasance, don't do bad, only do good, then you have a duty to share when that bad occurs. So, there's very little teeth in laws, expectations, policies driving when you should tell somebody. When you think about it, how many communications have you had with whatever board is you are certified under? The dental board, the board of physical therapy, and I'm making this up. I don't know what they report to. Nursing board, medical board. We really don't have that much communication with them. So is it up to me to report myself to them? Is it up to someone else to report me to them? And there's language in there, but what happens if you don't? Right. And generally speaking, there's not a whole lot of teeth if you don't do it. So it's really rest upon the shoulders of the individual. Now, you work for somebody, or you work in a facility. What are their rules? Are they telling you that you've got to go through the quality department first? Are they telling you you've got to go through the risk manager first before you can say anything so they can protect their interest? I don't know. Every hospital, every institution is different. So even if you want to say something, you feel like your moral compass is telling you, ethically, I've got to talk to the patient. I've got to tell them what happened. Can you? Will your institution that you work for allow you to do that? So it's a very difficult thing to define. It's just this really abstract concept of
Mm-hmm.
when should I report a medical error? And you look at this and you think, I mentioned the fact 200 to 400,000 deaths a year.
Mm-hmm.
If you do some very just crude math and you look at there's 6,100 hospitals in the U.S. and without taking account of size and scope and the differences between the two and not counting any other facility like urgent care where someone may pass, you look at that and you go, that's roughly 40 deaths a year per institution that was caused by a medical error. And I know that's not correct math, but think about the number. That is a very impactful number for an institution when they're thinking about what happens if a lawsuit is brought against each one of these cases. So really makes you think, and it really makes you wonder where to go with that. And if you should have anything in writing or set an expectation even.
Well, and while you're talking, my brain is definitely over here turning because I'm thinking, okay, I've worked in quite a few different hospitals, due to moving around. And I don't know that I've ever had a hospital tell me their expectation of what I should do if a medical error occurs. I don't recall that in my orientation at all.
You're right. And what you see is you see little things, right?
Mm-hmm.
Like pharmacy department may put out an extravasation policy. If a wrong medication is given, or if not necessarily wrong information, but let's say a highly viscous medication is given in a peripheral vein, and it gets inflamed, it clots off, it gets inflamed. What do you do? How do you treat it?
Yeah, I've seen those.
That's an error, right? Because it probably shouldn't have gone in that line. Not that the medication was necessarily incorrect, could be, but for this instance, or this example, it was put in a place where probably shouldn't have been put in, right?
Yeah.
And you're trying to mitigate the damage on the back end. So you'll see things like that, and what it does is it normalizes that occurrence. It provides a remedy, but by seeing those policies and seeing that, it also normalizes that occurrence as common and acceptable, when the truth is we should fix things on the front end and correct the expectations in the practice, and not necessarily on the back end fix the damage.
So talking about legal a little bit, there was, and I can't remember, this hasn't been that long ago, there's a lawsuit. I believe it was in Georgia, and a baby was born, and the family was not informed until later what had actually happened to the baby. Now, I saw that there was some lawsuits. So that's a legal obligation, or that's someone saying, well, I thought you should have told me. I think that moral versus ethical versus legal obligation in that scenario.
So, anything with kids is a very highly charged area, right? We love our kids. We protect our kids. It's biological. It's human. You have heightened, as my kid says it, my spidey senses, and so you're just automatically, Papa Bear mode, Mama Bear mode, watching over your kid. Unfortunately, when something happens to a child, regardless of their age, and this happens to be at birth, regardless of the age, we're super sensitive to it.
Right, yeah.
And overly sensitive, right? So it gets scrutinized more often than not. Lawsuits are in abundance against OBGYNs, OB practitioners. It's one of the most highly litigated fields because we want to blame someone, okay? As individuals, I have found through years of legal work, we want to blame someone, right? We don't necessarily, have a lot of feelings one way or the other about a lot of different factors involved in the suit. We just want to know, I didn't harm my child. Okay, I didn't do that. Someone else did. And it's a coping mechanism, right? It's a coping mechanism that we have, but we have it. We're human. That's part of how we're made. So that's a very litigious area. And so, knowing that it's a highly litigious area, this is where your moral compass comes in as far as the practitioner. Maybe OBGYN that delivered the child or was the primary physician for the pregnancy prior to the birth, what have you.
Mm-hmm.
Is it your responsibility to go and tell them? Well,
as a nurse,
as a nurse, you fall under the guise and the direction of wherever you're practicing. Mm-hmm. So that's a little bit different than a practitioner. But as a nurse, you have to fall under that. So it's difficult because, the studies today will tell you that if there's a medical error and you go and you own that error and you're sympathetic in your conversations, you talk about or you explain to the patient and family how you got there, what you're going to do to take care of them post-event, that you actually mitigate or reduce the risk of lawsuits, greatly reduce them. Again, people are looking for an answer, right? That's why when you don't apologize and you may find out years down the road and someone else knew and didn't tell you, you're just inflamed, right? You want answers and you want accountability. So they have found that. So we're moving today more towards talking to people and explaining that there are errors. But legally, there are some huge risks in doing that from a legal standpoint. In Alabama, we have a statute of limitations of 2 years from the injuring event. You must file a lawsuit within 2 years. Some people will say, I'll tell them, but I'll wait for my 2 years to be up before I tell them. It's not a complete get out of jail free card, right? So
right.
Also in the law, there is part of the statute of limitations is there's 2 years from the date of injury or 2 years from discovery of the injuring event, or 2 years from the date you should have discovered it. This came into play years ago, and there's been a number of examples of that. Had a surgical procedure, run of the mill, what have you, abdominal surgical procedure. Used to leave gauze in the abdominal cavity, right? They were put in there during the procedure. You get sewn up. They thought they had the count right. This is before generally there's a what you call a magnetic tip on them now that you can take an x-ray and it actually highlights before you close them up and you can make sure you get them all out. I don't know if everybody knows that, but they do that. They just want to be sure,
Sure.
Please don't leave anything in there.
Yeah.
But gauze actually will migrate through your intestines and you can pass it. And so people years later, 5 years, 8 years, 10 years later, there's a rag in their toilet. And they're like, what the heck happened? And they've been having pain for years. And so they go back and they sue. Hey, you left something in there. So
here it is. I found it.
Yeah, you don't want to be the one that had to bring it to them, but so there's some statute of limitations there do come into play and do affect the way people think about it. You can roll the dice. Hey, should I say anything at all if it's never discovered? So it's very difficult, but ultimately the disclosing of medical errors from no matter what type of practitioner you are, runs afoul generally of what most attorneys would tell you of defending a lawsuit of this nature. So it's a complicated process.
Okay, so an error occurs. What role is there a role that patients and families may play in investigating and analyzing these medical errors?
I will tell you that after 25 years in healthcare system, I will start with if a family member or loved one goes to the hospital, I or someone I trust are with them from the moment they step foot in the hospital to the moment they leave. The reason is, healthcare is complicated, right? It's not easy. It's a science. It's not an art. An art can be defined. Science is still a work in progress many times. So it's fair if it is a science and there's hypotheticals and there's testing things out for you to ask questions and poke holes into theoretical theories of, I'm going to prescribe this medication. Okay. So I think it's very fair to ask those difficult questions and be with people and make sure things are done correctly the whole way. Because there is such fear about repercussions, either fear for loss of your job, if you work in a healthcare setting, if you were to say something, or fear of a lawsuit, many people don't speak up. So as a family member, I want to be there to prevent the error if possible, if at all possible. But two, I want to be there to be able to ask questions. And I think that's where patients and families really can impact things. You need to be able to get in, ask the questions, and figure out what went wrong. Now, there's a way to do it. Don't come in like a bull in a china shop and say, I want answers.
Yeah.
But truly, when you think long term, now, could it impact care down the road, your decisions, healthcare decisions? It could. So I think there's a very valid argument for families to be involved and try to get to the bottom of what happened to provide the best care possible, or ensure that the best care is provided down the road for their loved one.
Well, you were talking a little bit about fear of repercussions, so we're scared to admit when something happens. So how can a healthcare organization really help to create this just culture, as the hot topic word, that really supports reporting errors while also holding professionals accountable when they do make mistakes?
Hospitals, institutions really have to structure their processes, right? When I say structure their processes, the court system has generally deemed quality reporting as undiscoverable, meaning as a plaintiff's attorney, I could request that you hand me every document under the world, but I don't have to hand over certain ones. And the quality reports and process improvement documents don't have to be handed over, right? Because it's kind of like the hospital secrets of everything wrong. And we don't want to just give it to you because you just will show that to everybody.
Right.
So you have to have a reporting structure. And this is why if you've ever been involved in, say, a root cause analysis or a process improvement situation, it's generally led through the quality department. And the reason is all those documents in your research and investigation and findings can be held private within the institution. That's not necessarily a bad thing, right? We want to encourage improvement. We want to encourage fixing issues. So we have to provide institutions a route to do it that won't bankrupt them through lawsuits.
Right.
I mean, that's kind of the bottom line. So hospitals can start this process, and the biggest issue for a hospital system or any healthcare institution is, okay, you've established a system. You have an event reporting system. You educate. You want your frontline staff to report these things. You want them to do this. It's all private, right? It's secure. Post-COVID, healthcare is still topsy-turvy. Hospitals generally, on average, have between a 1% and 3% profit margin, which is very, very low for any business. And yes, people have to understand these are businesses. We want to think they're just altruistic and that's why they're there to help us and no matter what. But they are businesses and they have to make money to pay the light bills and pay their staff. We're in a national nursing crisis. We're short in other disciplines too. Yeah. So all of these things add on layers and layers of complexity. We have a nursing issue. We want to do a root cause analysis, and we say we want to get together for 1 week, map out the process, figure out options, educate. How many nurses can you take away from the bedside for a week?
None.
Can you back them? Right.
No.
So how do you perform these improvements? Right. So it's just a very complicated issue that you think topically, oh, this is easy. The roadmap's out there. we'll get these people together. We know exactly which fishbone diagram and all these different things we can complete and how to change and improve. But theory versus practice is very different today.
Absolutely.
So, it can be done. It absolutely can be done. Hospital systems, pick on them. Structure things correctly. Be proactive. Monitor for change. But at the end of the day, you've got to dedicate resources that allow for a just culture to exist. Mm-hmm. If a just culture exists, we all think about just culture as, okay, we're not penalizing people. And that's really not what just culture means. Just culture means that, to me, that if there's no intent to do harm, no intentional bad act, then it's essentially a learning opportunity. If there's an intentional act or omission that caused harm, well, that's still subject to discipline, right? Mm-hmm. Not only from your institution, but maybe the licensing board or even criminally. So, but if it's not, are we capitalizing on those unintentional acts that can make us have better performance and reduce errors down the road where we don't have to worry about disclosing errors? We're just providing better care. And so there is a pathway to do that. It's just resource heavy, and it's difficult, and it's very difficult in today's healthcare and economic environment.
Absolutely. I mean, I talk to my students a lot because we are talking about interviewing people, and they'll say, well, we'll bring some bedside nurses in. And I'm like, well, how are you going to cover their shift? What is your plan for being able to let them come down and not stressing them out? Because then they are thinking the whole time they're there, I got to do this, and this when I get back, and I only have 4 hours left in my shift. And, so, I mean, that's definitely something to think about in all aspects of leadership in any organization. Oh, well, we have come to the end of this episode. Thank you, Jay, for shedding so much light on the core ethical tensions at play in healthcare, and really just highlighting the need for the sensitivity, compassion, and of course, commitment to continuous improvement in healthcare. Join us for episode 2, where Jay and I will discuss best practices and practical strategies for fostering an environment of transparency, accountability, and trust in the face of medical errors.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.